He has a nice one.
Favor? In your opposition? And Madam Secretary is abstaining, that's correct.
And I'm abstaining because I'm not really on this committee.
Okay. Therefore, we have 3 in favor,
Yep.
none opposed, and 2 abstentions. Okay, so we will approve the minutes. We have 2, or probably 3 primary things we want to do today. First is talk about the drug coupon study which legislature has requested of us, and so we will walk through that. Second, talk about nurse practitioners in the primary care workforce, and then third is administrative complexity, which I personally know increases my aspirin consumption quite a lot. So we'll dive into all of those. I think some of these are things that are going to show up again at the cost trends hearings, which are coming up very soon. And some are things that are part of our ongoing work. So we're not going to be making monumental decisions today, but I think it's a good chance for us to help steer where we're going with these. Is that an accurate summary? Is it? Very good. Then why don't we dive right in with the prescription drug coupon?
Before we do that, just really quickly, because we do have a full agenda, as you said, Mr. Chair. This really, in a lot of ways, three big topics here, and many of them are teeing up exactly what we're going to be discussing at the cost trends hearings. So just wanted to highlight again, our registration for the cost trends hearings is open now. So please go onto our website or check out our HBC info and register for the hearings. As you can see here, we have 4 main panels. 1, confronting complexity in the healthcare system. 2, pharmaceutical market trends and cost drivers. And then on the second day, we'll focus on strengthening primary care and behavioral health care, as well as provider market trends and cost drivers. And the 3 topical areas that we're going to be discussing at length today are directly related to 3 of those panels: confronting complexity, pharmaceutical market trends, and strengthening primary care. So very excited to get a lot of new information. As you can see, the handout is quite long, and there's a lot of slides here. So we're going to try to move quickly through all of this information, but do want to reiterate this is an opportunity for the commissioners to weigh in, give us advice and feedback and insights as we continue these 3 work streams. So with that, I'm not going to say anything more, and I'm going to have, we'll turn it over to Sarah. Yeah. to start us on prescription drug coupons.
Well, Sarah's coming up, I will just say that in past years, I found it quite helpful to have some thought to these issues before the cross-trans hearings, so that we at least have a sense of our thinking and which way we might want to go with the discussion and so on.
Good morning, everyone. Please bear with me in advance of the hassle voice. Okay, so today we're going to be presenting our full results of the coupon study. We presented on the trends component at our last meeting. For the public, we'll run through the background very quickly, and we're really trying to devote most of our time to the new material. As we discussed before, the history of coupon legislation in the state began in 2012 when coupons were allowed for the first time. There was an important provision that excluded the use of coupons when there was a direct AD generic. But the law also sunsetted this provision. That sunset was extended a few times, which brings us to the most recent piece of legislation, which delayed the sunset until January 1st of 2020 and directed us to conduct this study. So we are charged to study a number of aspects, including the number of value of coupons, their impact on alternatives, effects on adherence, and other questions, including total spend per impact. We are defining coupons as offers from a manufacturer that reduce the amount of patients' cost sharing. This is distinct from patient assistance programs that may help patients on the basis of their income or being able to afford their medicine. I'll move through this for the sake of time, but we did want to tee up some of the sort of the fundamental questions and controversies that make coupons an important topic for study. We felt that the points that were brought to light in our public listening section in May really highlight the issues on the table here. We have payer perspective that coupons, well, they set up their tiering to provide incentives for members to use lower cost treatments when those are available, and they expressed position that coupons weaken those financial incentives that being set up, ultimately leading to higher premiums, and also that coupons can hinder their ability to negotiate lower drug prices. Patients, on the other hand, described a very real situation of facing high cost sharing and deductibles and cost sharing, and using coupons not to sort of increase use unnecessarily, but to afford needed medications. It is noteworthy that there was a range of patient perspectives expressed, including Healthcare for All, which expressed concerns about coupons as the solution to affordability, given the potential impact on raising premiums. And manufacturers have really stressed the value of coupons in increasing medication adherence. So we used a number of sources for our study, including data from Symphony Health, a data vendor that we use that has a richer data than other sources available to us, including on actual coupon use. Okay, so at our last meeting, we discussed the market trends. So I'll go through that quickly, but do want to highlight a few key points in the TF discussion for the new material today. So overall, much of our research supports the idea that of people who use coupons, there's a small number who are using coupons to cover a very high amount of cost sharing, and then a larger majority of coupon users where the value is more modest. So the average coupon value is $229 in 2018, but that average is considerably higher than the median of $55. So you can see on the distribution below, half of all coupon use is less than $55, and 75% is less than $55. So coupon programs have dramatically expanded their uptake since 2012 in terms of the number of brands that offer coupons. Those are the gold numbers, rising to about 700 unique brands in 2018. Large growth in the percent of eligible claims that use a coupon. That is, of all branded drugs that offer a coupon, how many, what percent of patients, or what percent of claims actually use a coupon, and then the average value of the coupon itself in those numbers. So we discussed the top. I have a suite of top jobs if you need. So we discussed at our last meeting the top drugs by volume and by individual drug and by category. So we have expanded that, so I'll just spend a minute on this. The bars at the bottom show the top therapeutic categories by coupon, of coupon use by volume. Diabetes is the highest by far, 20%. Next to antivirals, mostly HIV medications, antiarthritics, respiratory therapy, for example, inhalers, hemostatic modifiers, which is anticoagulants to prevent stroke. Yes.
Why is such a low percentage? Why such a low percentage of eligible claims that use coupons? Are people just not aware of it?
That's a good question. Well, probably a range of factors. One, people may not be aware of them. Two, patients, if you don't have a large cost sharing, it may not be sort of financially advantageous. It might be a wash. For example, if you have cost sharing of $10 and the coupon says, the coupon may be pay no more than $15, so it's not.
I just want to add one note there. We do see that there's variation among different types of drugs in terms of that uptake. So we do see that there are certain classes of drugs where a lot of patients are using their eligible coupon. And that, I think, in the antiviral case, is that one of the categories, Sarah, where there's a higher uptake?
I think if you look at the top section here by the top drugs, that gives a sense of the range, to your point, David. So the Truvada, the one with the highest uptake, is at 40% of all claims. Truvada is prepped to prevent transmission of HIV as well as used in
On that point, what are the most common modes for manufacturers to advertise or get these coupons to the consumer? Is it typically through a physician or is it through other modalities?
We're aware of physicians as a route, giving them to physicians to provide to patients, as well as being available on the internet.
So imagine that.
I believe there's also paper forms of coupon that people either get through physician's offices or other means. Anecdotally, we've seen a lot of coupon programs that require people to go through a registration process to make sure that they are on commercial insurance and that they are eligible. So a lot of the coupon programs do go through an online program and a use card that lets you use coupons at the pharmacy.
Okay, so we looked back and compared how the top categories have changed since 2013. We used 2013 instead of 2012 to allow for sort of the first full year of coupon use. There's some interesting changes that highlight some of the dynamics in coupon use. So in sort of light red, it's a little bit hard to see the first top categories. There's been a few cases of big swings in what were the top categories. So, and and if you see diabetes, for example, that was the grew from the rank number 7 highest in 2013, and 4% of all total coupons used to the highest rank, 20%. So, and some other changes as well. So, some of the factors that result in change in rank include the entry of new branded products, the loss of exclusivity, generic entry. That was a big one, for example, in statins when Crestor went off patent, for example. Policy changes such as the implementation of the ACA. I think we see that in the change in the contraceptives from 11th highest in 2013 to 26th in 2018 as that provision, the $0 cost sharing provision went into effect. Changes in prescribing trends, certainly a factor in analgesics, new medication dropping from rank number 8 to 28, as well as changes in benefit design and drug prices. We see a lot of these dynamics in the in understanding the story of why diabetes changed. So in those ensuing years, there was a large number of new brands that entered. A much higher percentage of brands offered coupons, resulting in a higher number of brands that offered coupons. And we see that coupon use among eligible brands increased dramatically from 3% to 14%. And some important dynamics in increasing coupon use, to your earlier question, are increases in the prices for diabetes therapy, with average spending per claim increasing almost doubling at 93%, and patients also being asked to spend more out of pocket. So their liability per claim growing from $38 to $57 on average. Okay, so turning to adherence, so we did a large literature search. There's quite a lot out there on adherence, and we found overall that the impact of coupons on adherence depends on the cost of the drug and on the value of the coupon. There is a well-documented relationship between the cost of the drug and adherence, finding a sort of abandonment threshold at $125 to $250 per claim. In studies where the out-of-pocket cost of the drug are small, the value of the coupon are small, we found that coupons were found to increase adherence, but more modestly. For example, a study of statins did find an increase in adherence, but the improvement was likely too small to impact clinical outcomes. In contrast, where for high-cost drugs, and in cases where people have high cost sharing on high-cost drugs, we found that the literature cites a much larger effect, a much larger impact on adherence. So to give sort of a sense of, there was a very large study that found that coupons reduce the proportion of specialty drugs where patient cost sharing is more than $250 from 12% to 1%. So again, with that sort of $250 threshold, that gives a sense of the magnitude of impact. So we'll turn now to our new work on spending. First, giving an overview of the kind of the range of ways that coupons might be expected to impact spending. So that could be through patients filling prescriptions more often, such as improved adherence, which we think is good. Patients filling new prescriptions, perhaps if they did not previously fill due to cost, that might be a good thing. That might also be an example of low-value spending if it's use of low-value drugs, or reducing incentives to try a lower-cost alternative first, such as perhaps you trying over-the-counter treatments for acne before a prescription version, and then shifting use to higher cost products as opposed to lower cost alternatives. The questions that we were tasked with studying fall into that third bucket of shifting use. So this is the framework for categorizing drugs that we use. This is from a recently published study from USC that bucketed drugs that offer coupons into 4 categories. The first is drugs with a direct generic equivalent. These are not eligible in Massachusetts. The second, and this is where our work mostly falls, is cases where there is not a direct generic but a close therapeutic substitute, so perhaps an alternative in the same class that is generic. The third is where there is an alternative branded drug that may or may not be lower cost, and then the fourth is no close therapeutic substitutes. This is what we have considered or discussed more calculated orphan drugs. And I do want to really highlight here that in the cases of 2 and 3, we are in no way saying that these drugs are exactly substitutable. Patients have preferences. Some drugs may work well for one patient, some alternatives may work well and not another for a given patient. Our goal is not to suggest that patients should not have access to one that might be higher cost, but rather our goal is to test whether coupons increase spending through allowing patients to bypass incentives that might have resulted in a lower cost alternative where it is appropriate. Okay, so the first category, I'll walk through each of these, is on drugs where there is a direct generic equivalent. Again, these are not allowed in Massachusetts, but the research on this is I think important for contextualizing why that exclusion exists in Massachusetts. So there was a study comparing, in fact, Massachusetts and New Hampshire, where coupons are allowed, that concluded that coupons were associated with lower generic use, higher price growth, in fact, for those branded drugs that do offer coupons, and higher total spending. There is one aspect of this that we want to highlight, which is that the fact that coupons are not allowed when the generic enters the market highlights the issue of high prices for certain generic drugs. So when a generic is introduced at a high price, when patients have a plan that leaves them with high cost sharing, that may present affordability challenges for patients with high deductibles or high cost sharing. And we've highlighted the example here of Gleevec, which is used in treatment for leukemia. The average price for the branded drug was $10,000 compared to the generic at $8,000. Okay. So we did not look at the utilization of alternative branded drugs. We concluded that it wasn't feasible because without rebate data, it's hard to have a sense of the actual cost savings. So I'm going to turn now to Yua to talk about our work on the category 2 analysis.
Good morning, Commissioners. Okay, so I'm going to be focusing on the drugs that don't have a direct generic equivalent, but might have a close generic alternative. So what we were calling category 2 in that table of framework Sarah showed earlier. An example again is Lyrica and gabapentin. Okay, so to understand the impact of coupons on this category of drugs, we analyzed the utilization of the brand drug that offers coupons relative to their close generic alternatives in the commercial population. And we used Medicare as a control group because Medicare does not allow coupon use. So in order to do this, we needed to identify a list of drugs that are appropriate for this method. So first we start out with a broad list of drugs. We know based on national estimates and our Symphony data that there could be more than 200 branded drugs that fall into this category, but we focused on 29 of them that had the highest expenditure. And then from the list of 29 drugs, we really want to make sure that a Medicare and a commercial comparison is appropriate. So we worked with our pharmacist advisor to further restrict the sample. So for for example, one of the 29 drugs was an Alzheimer's drug. But we know that Alzheimer's might manifest differently in a younger population, which might be on commercial insurance, compared to an older population that's on Medicare. So for that, and that could affect prescribing choices. So for that reason, we excluded the Alzheimer's drugs from the analysis. So that's just one exclusion criteria we used. Overall, we were conservative in our approach and used a number of different exclusion criteria and ended up with a list of 14 drugs for this analysis. And because each drug enters the market at different times, for this analysis, we averaged the utilization trends for the two most recent applicable years for each drug. Okay, so here are the results for one of the 14 drugs, which is a blood thinner. I'll just walk you through the bars. So what we show here is the utilization of Eliquis, which is the branded drug that offers coupon, relative to warfarin, which is the close generic alternative. So the left bars are for Medicare, and what we show here is that for every 100 prescriptions of warfarin used, which is in blue, there were 21 prescriptions of Eliquis. And on the right, we have similar bars for commercial. Now, in theory, if we assume that coupons had no impact on utilization, we would expect to see these ratios to be similar. But what we see here is that the commercial use of Eliquis is almost twice as high compared to Medicare. Okay, now going from that one drug to all 14, the blue bars are for Medicare and the yellow bars are commercial. So of the 14 case studies that we included in the analysis, the use of branded drugs was higher in commercial for 10 of them, and by higher, we've defined it as 25% higher. And for the other 4 cases, the use was similar between commercial and Medicare. And we're not showing the specific coupon use for each of the drugs here, but on average, coupon use was higher for the 10 drugs with higher commercial use compared to the 4 that had similar trends between commercial and Medicare.
Just one question on this slide. I see that you have different years. Can you just speak to why you chose different years?
Sure. So I'll give one example. So Abilify, which was the 3rd drug, I believe the generic came on the market in 2015. So we picked the 2 most recent years before the patent expired, because once a direct generic comes on the market, you cannot use coupons anymore in Massachusetts. That's why, and because the drugs have come on the market in different years, that's why they're different years for each drug. Okay, so how does this utilization impact spending? This is how we modeled it. And again, using Eliquis and warfarin here as an example. So the left bar here shows the observed commercial spending per year in our data. The yellow is for Eliquis and the blue is on warfarin. And on the right, we show what would the spending look like if commercial utilization trends were like Medicare's. So the alternative spending here, you can see that the spending on Eliquis would go down and the spending for warfarin would go up. And the difference between the 2 bar is the spending impact on this one particular drug, which is $2.4 million in our data. Okay, now we did this spending modeling for all 14 drugs, and what we found is that on average spending was 18% higher per drug than it would have been if commercial utilization trends were like Medicare's. That translates to an average of $1.4 million per drug per year. And because the data in Symphony is a subset of the entire Massachusetts commercial population, if we extrapolated to the entire commercial market, that would be about $3 million per drug per year. And adding all 14 case studies together, the spending impact could be about $45 million per year. The limitation of our analysis, of course, is that we only included 14 case case studies in this analysis, and we do not know that the results from these 14 case studies could be applied to all the drugs that fall into this category. In addition, while we did our best in selecting drugs that are appropriate to compare between commercial and Medicare, of course there might be other factors that contribute to higher brand use in the commercial population that we're not accounting for here. So these results are suggestive, but they certainly give an indication of the potential impact on coupon use.
Thank you. So, in summary, we did find that coupon availability is associated with lower generic use and higher total spending. And although they may result in potentially unnecessary higher spending, some patients don't have alternatives and they depend on coupons to afford their drugs, particularly patients with high cost sharing, and conclude there and welcome any questions.
I'll start off the general thoughts. So first, thank you. That was really quite impressive and extremely well done. My general thought is, if you go back to slide 23, which has the different reasons, which, as you said, some may be valuable, some are less valuable, for why patients use coupons. We could recommend, excuse me, the legislature could adopt a law that says that there has to be rebates to the insurers based on the third category. That is, that someone, maybe you, would determine what share of the use is by patients who had likely shifted from less expensive therapeutic alternatives to more expensive therapeutic alternatives. And that would then get incorporated into a rebate payment, just like the other rebate payments. To my knowledge, there's nothing that would prevent that from happening, and maybe we should put that on the agenda for the legislature. I didn't mean to summon the evil ghost.
David laughed just as I was going to interject into our comments. It's certainly an interesting idea, and I think that is one avenue to address the higher impact on spending that we found. I think it would be important to look through to understand fully what impact that might have on any unintended consequences with sort of a new set of incentives, but it's certainly an interesting option.
We're discussing. That's better than many other do. Other thoughts? Yes, Chris.
I'm an interloper. Can I ask questions?
You can indeed ask questions.
Just one caution, and that's the one slide that had Nuvigil and Eliquis and the differences as the sort of the poster children for this discussion. It gets tricky with Medicare because with people over 60 years old, because the side effect profile is different. Nuvigil is a stimulant, and it can cause irregular heart rates. People over 60 have 10 times the rate of atrial fibrillation, for example. So it may be an answer why Nuvigil is prescribed in an under 65 or under 60 population. And the same holds for Eliquis, because the bleeding profile of warfarin. Look, I'm a primary care doc, but I'm going into an area which is a little bit beyond my capability. But warfarin causes significant bleeding, and so Eliquis has become a popular drug because it causes less bleeding than warfarin. If you fall down and hit your head when you're 75 years old, bleed into your head, you don't want that to happen. So the indications for these drugs are different in the elderly than they are in the commercial population, and it's another factor that has to be applied. And I think in the case of those two drugs, it would discount the impact
certainly, it's a very good point, and we did try to be conservative in working with our consultants about using drugs that would not be expected to have different use in commercial versus Medicare populations, but certainly there may be reasons that that haven't been accounted for. I would say that these are ranked by the absolute difference, but when you look at the ratio, the sort of the percent difference, the ranking actually is different than the one that's here. So it so overall there may those might have had a smaller difference in the commercial versus
Both of
Medicare
these are
population.
used. Both of these ones are used more in the commercial than the Medicare.
What's that?
Both of these are used more in the commercial than the Medicare populations.
But both drugs are used in both populations.
No, I understand, but I would have guessed the spirit of your comment was that they should be optimally used more in the Medicare population than the commercial population.
Right. Eliquis should be used more in the Medicare population.
Where it's actually the reverse.
But still, it still
Yeah.
applies.
Just a little bit more about how close therapeutic
And
alternatives
Lauren,
to
if I can, excuse me, just having pharmacist consultants, I think, is valuable. But in this case, having a cardiology consultant as a contributor probably would help explain that. Sorry.
Just you can provide a little bit more context on how close generic alternative is defined versus a direct.
So the direct is whether it's equivalent in every way. The alternative is a different drug, but they may be in the same class. They may be there may be multiple options for a patient to try in the same category. For example, for ADHD, generic Ritalin versus Concerta versus any number of drugs that a patient with a given condition might use.
And so you're saying that earlier to the question about the modality of how consumers are accessing coupons, if the physician if it's primarily through the physician office, did you get any background information or feedback from the extent that physicians have a role to play in terms of making the alternatives, making the patient aware of the alternatives, just in doing your scans of other states and how coupons have played an impact? Just because I would be curious to know where a consumer is attracted to a coupon, whether there's awareness or even the opportunity for them to be aware of close therapeutic alternatives, and whether the physicians want to play a role in making that information available.
It's a really good point. I think that speaks to to a need for physicians to be more and providers to be more aware of the cost sharing that patients face and what how the choice might financially impact a patient if there are a number of alternatives that might work equally well for a patient, at least to try for a first time.
When people utilize coupons, do you find the adoption of that particular drug is long-term, or do they, after a short period of time, stop taking the drug? An example of that is, I saw a study on folks with high blood pressure. You're not looking at significant cost, but the results were that 50% of the people diagnosed with high blood pressure would stop taking the drugs after a 6-month period of time. So I was just wondering, and obviously the impact of that long term is significant given what else can happen. So if coupons helped retain adoption?
We didn't look at that question specifically. It would be hard to certainly, if a patient wasn't, if it brought the cost sharing down to a level that was affordable for a patient or in line with alternatives, then there would be a financial incentive for them to change as long as they could keep using the coupon.
A couple of comments, if I may, one to your question about the, hypertensive patients are notorious for not taking their medications over time. A lot of it has to do with side effects that they find uncomfortable and can't find the management, and also they don't feel bad. So if you don't feel bad, maybe you don't take your pill. But to circle back to Dr. Kreider's comment, I'm wondering, Sarah, in the review of the work that you did you have the opportunity to ask prescribing clinicians or a panel of prescribing clinicians what other factors they would see, similar to Dr. Kreider's comments, that might describe or account for a percentage of the difference? And I'm thinking, in following up, it's been a long time since I've been in primary practice, but I have distinct memories of circumstances where other diagnoses get in the way. While you might want to use one medication, you discover that medication exacerbates an already existing condition. And so I think there are a lot of variables that would help tease out what the real impact of the coupon is, what the confounding variables might be. And I just wonder how, going forward, you might be able to capture that information to help you identify the true relationship that's there. And I don't know if you've done that or if that's something that is part of the process.
Well, there will always be a number of factors that we wouldn't be able to account for. So we try to address that by being conservative on which drugs we included in our case studies. And I think even though there are lots of different factors for different individual patients, it does appear that the trend for the majority of them is consistent.
So you feel that you've adjusted for that at the beginning of your process by identifying very, very conservatively the drugs that you want to consider.
And we did also, another exclusion criteria was if clinical guidelines favored one particular alternative over another, we excluded that.
I can give you a few more examples on the exclusion criteria if that helps to explain. So I mentioned the Alzheimer's example, where the condition might manifest differently in a younger and an older population. Some of the other considerations we had, I believe one of the 29 drugs was a smoking cessation drug, and because some of the alternatives are over the counter and we cannot really capture over the counter use in either of our data, that drug was also excluded. Some of the other considerations we had were route of administration. So if I think one of the 29 drugs was a pain medication that comes in patch form, and if the patch is more convenient for patients, we cannot assume that the patch is equivalent to another pain medication that you take orally. So we also excluded that. There were a number of these kind of exclusion criteria that we went through that led to the score team, but certainly, to your point, Commissioner, there could be other factors that we're not counting for.
And I would just add, as we still have to put all these results together into a written report. So I think there is an opportunity, and part of the purpose of this meeting and presenting these results is to share these publicly, to be able to get feedback. And so as we think about crafting a final report, I think we have an opportunity for more stakeholder feedback, more consultation with experts to make sure that we're capturing this and characterizing it the right way. Because I don't think that we're characterizing this as a definitive, direct, a causality. And so I think we need to be very careful about how we describe this and this relationship. We do see this as a directional finding that we do feel statistically holds up. But I think let's be sure that we're making sure that we're categorizing and accounting for, or at least being able to describe some of the different confounding variables and factors to appropriately and cautiously craft this final conclusion.
I know we need to move on, but to put a coda on it, as a question I ask you, is it possible that federal regs are a defining variable in this equation? In other words, if Medicare allowed coupons, would you see Eliquis at 10 times at the blue bar being 10 times the yellow bar because it's a more effective drug? Is that possible? Nate? Or Don, you were around. Do you know what? You've been there. You know this was put in place, I think, in federal policy because of the widespread availability of generics.
There's not a single economist who would dispute that this would go up if you allowed the coupons. It's just people are sensitive to price.
Yeah.
And so you let them, I mean, that's why they're doing this. Right. So you let them lower the price and people will consume more of it. And sometimes, as we were talking about, that's good, and sometimes that's bad. And I think we really kind of need to think about what sorts of advice do we give to have the good stuff happen and not the bad stuff. But there's absolutely no doubt in my mind that these conclusions are correct, whether the correct percentage is 23% or 19% or 46%. I have absolutely no doubts about the truth of the statement.
What I can tell you is that the proportion of generic use in Medicare is extremely high, and it's generally thought to be a real success program. It's been widely praised.
And an important point about why Massachusetts does not allow coupons in those where there is that direct generic equivalent.
One thing to David's point about feedback to inform the final report, I don't see any information here about the longevity of the coupon use. I think that's an important factor here is if somebody does, if the manufacturer does offer a coupon and the consumer takes it, how long is that coupon available for that drug? Because all these drugs, it looks like, are primarily for chronic conditions. So it would be helpful to understand how long are these coupons available.
Thank you. Thank you very much. Okay. Going to move us along to nurse practitioners. This is getting increasingly in need of medication for us. It's a good thing we have the nurse practitioners here to help us out.
Hello, commissioners. I'm excited to be here today to talk about two topics that I think we were both interested in, primary care and healthcare workforce in one. And I know I'm talking to some people with experience in primary care while we go through these slides. So hoping for your input. So today we're talking about the role of nurse practitioners in the primary care workforce. But first, I want to talk about a little bit about why we're focusing on their role in primary care specifically. So there's an emerging consensus that more primary care-oriented healthcare systems will improve access, outcomes, and reduce costs. There's evidence that in states with health systems that are more oriented towards primary care, they have better health outcomes and lower spending. A recent report authored by the Patient-Centered Primary Care Collaborative shows that Massachusetts has a below average proportion of commercial spending in primary care compared to other states. And we know that a number of states have implemented policies directing increased primary care spending. For example, Rhode Island required payers to increase the proportion of spend, and a recent research report indicated that their total health spending declined over this period. The authors are quick to note that this is not causal, but the health spending did decline over this period. And in May, both Colorado and Vermont passed legislation. So we're seeing this goal towards more primary care spend across several states. In order to increase primary care spend, though, we have to consider the primary care workforce. And so, using some data provided by our market oversight team from the registry of provider organizations we have here, a trend that is interesting to in the context of saying that we want to spend more on primary care. Notably, we have some growth in the physician workforce, but most of that growth, 7.7% of the growth is, we see 7.7% growth among specialists, but only 1.7% growth around primary care physicians. So we're seeing some more physicians, but most of that growth again is in specialists. And when we look at where the primary care physicians are practicing, we see that primary care physicians per capita are not distributed evenly across the continent. Here we have our tie into why we want to talk about nurse practitioners in the primary care workforce. This is from a paper authored by our own David Auerbach, talking about what does the supply of physicians and nurse practitioners look like it's going to be in the future. And here we see a huge projected growth, 153% for nurse practitioners. So when we're talking about the primary care workforce, we can increase access to primary care potentially by using this new forming workforce. But we're here today to talk about what we see in Massachusetts around the role of advanced nurse practitioners or nurse practitioners. And particularly, I want to talk about, as some background before we get into our data that Hannah is going to present. I want to talk about how Massachusetts has a restricted scope of practice and how if we ease the scope of practice, we may see that primary care access is increased. And particularly in Massachusetts, nurse practitioners have to have a contracted agreement with a physician, and they also have to have agreement for prescribing authority with a physician. And I'll talk about how this is a little bit different than our neighboring New England states in a minute. The reason we think nurse practitioners are going to be effective in helping increase primary care access is we know about 50% of NPs work in primary care. In fact, the origins of nurse practitioners is to increase primary care access for underserved communities. As I showed on the prior slide, the supply of nurse practitioners is larger and grows more rapidly, where, and in particular, the supply of nurse practitioners grows more rapidly where there is full practice authority. That has been shown by research. In addition, in states with full practice authority, NPs have, there is some evidence coming out that NPs have more buprenorphine prescribing waivers, which is important when we talk about the opioid epidemic and access to evidence-based treatment. States that have expanded their scope to allow full practice authority saw increases in primary care utilization, which research has tied again both to health outcomes and to decreased spending. And something that we're passionate here about at the HPC is decreasing emergency department use, and nurse practitioners have also been shown to decrease emergency department use. In terms of quality of care, researchers have found that both primary care provider physicians and primary care nurse practitioners have comparable quality of care. And a recent study finds that nurse practitioners may even end up with a little less healthcare spending for those patients who are managed by NPs. Now, as for scope of practice, like I mentioned before, Massachusetts is a little bit different than our neighbors. So both New Hampshire and Rhode Island allow full the ability to practice without formal physician oversight upon licensure. Maine and Vermont grant full practice authority after about 24 months, and Vermont requires at least 2,400 hours of collaboration. In these cases, the supervising party could either be a physician or a nurse practitioner. Connecticut allows full practice authority after a longer time period, but then still requires written collaborative agreement for prescribing specifically for Schedule 2 and 3 drugs. But otherwise, the nurse practitioners can practice independently. And again, Massachusetts is an outlier here because NPs are always required to have a collaborative practice agreement with the supervising physician. And they cannot write prescriptions without a physician oversight. And you know, although we allow insurers, or we tell insurers that they have to allow members to select a nurse practitioner as their primary care provider, that nurse practitioner is still under the oversight of a physician. So today we're going to talk a little bit about the research we've done and present some original research. We're going to describe the nurse practitioner workforce in the Commonwealth. We're going to talk about who these NPs are, how many NPs are acting as primary care providers, where they practice, who they provide care for. We're going to look at it with a couple of different lenses. One, we're going to look at NPs who have been identified in the payer directories and by insurers as primary care providers, and then those NPs who are acting as primary care providers based on utilization. For this, we've used a variety of data sources. Several of these are familiar. And in addition, we are using the CMS National Plan and Provider Enumeration System Registry to identify even more nurse practitioners than we would be able to with our normal data sets. I also want to highlight that the Massachusetts Department of Public Health has a licensure renewal survey that all nurses and advanced practice nurses complete if they are renewing their license online. So we have some data from that to share as well. And with that, Hannah is going to talk about some of our research.
So we'll start off by reflecting on some national data sources that indicate that there are around 6,300 nurse practitioners actively practicing in our state of Massachusetts. Based on practice specialty information that's available through CMS and PPS, we find that a large proportion of NPs are trained as primary care, as other sources have indicated. When we turn to our claims data, we're able to try to understand which providers are acting as primary care providers for patients in Massachusetts through two ways. One way is when a payer indicates that a particular provider serves as a primary care provider, and the other is when we observe traditional primary care utilization patterns and we're able to make that connection between a patient in the APCD and a particular provider. These three boxes on the right indicate how these two modes of identifying a primary care provider demonstrate a disconnect between who we would expect is a primary care provider based on what a payer tells us and what primary care utilization indicates in our claims data. And so on the top, we see that there are 141 NPs that are distinctly identified as a primary care provider through a payer record. The middle box demonstrates the overlap between these two methods, so a large number of the primary care providers who are nurse practitioners that a payer indicates are also identified through primary care utilization methods. But the last box that gets close to around 2,000 nurse practitioners really demonstrates that there is a much greater number of nurse practitioners that appear to be providing a large amount of primary care services than we would expect based on what payer records tell us. So when we shift our focus towards a member-based perspective and looking at, on this slide specifically, commercial members, we again see this disconnect between nurse practitioners who are acting as primary care providers, where in many cases a payer reports that a member has a physician as their primary care provider. And that is the largest blue circle that you're seeing on that graph, where around 26,000 commercial members are assigned a nurse practitioner as their PCP based on their primary care utilization, but a payer is reporting that a physician is actually assigned as their primary care provider. We see, yes, of course.
In terms of the cost, again, this is new to me. If the NP is effectively reporting to a physician, and the physician is ultimately responsible, in terms of the payment from the payer, is the payment higher because you're paying two versus one? How does that work?
So I'm glad that you're thinking about that, and if you don't mind holding on to that question just a little bit, we will get there in just a few slides. But you're right on the money. So again, we see a considerable overlap of around 4,000 members that do match up where a payer reports that a nurse practitioner is a member's primary care provider, and we also see that for utilization. and a much, much smaller group of patients where members are actually assigned a physician PCP for their utilization, but a payer record assigns a nurse practitioner PCP. And so I'd like you to kind of keep this distinction in mind, but going forward, we will rely on a utilization assignment method to determine a member's primary care provider for the purposes of understanding how providers are functioning in the current healthcare system. We believe that there are important things to know in terms of what payers are telling us about who a PCP is, but that for the purpose of this research, understanding through utilization from somebody's primary care provider is more important as we answer the following questions. So we first started by comparing the population who is linked and attributed to a nurse practitioner PCP or a physician PCP to see if there are any underlying differences. We see based on volume that there is a much smaller group of people who are found to be attributed to a nurse practitioner primary care provider. They are more likely to be female, more likely to be a little bit healthier based on their risk score that we can observe, and they're more likely to be a little bit younger. We also see that unadjusted total spending per member per year is approximately $1,000 lower for members of a nurse practitioner PCP. And although this graph is explicitly for commercial members, we do see these trends again in a MassHealth managed care population as well. So when we step back, yes?
Are the cost differences adjusted for
These,
risk?
not currently. So these cost values are not adjusted for differences in risk, age, or sex by any means. So when we take a step back at the community perspective, when we ask the question, who are nurse practitioners serving currently? We see that nurse practitioners play a much larger role in providing primary care in more rural areas. And on this slide and the following slide, you'll see figures for the commercial population on the left and MassHealth managed care organization members on the right. But we see similar trends in both populations of patients, where the percentage of members attributed to an NP are much greater for people living in communities that are farther away from urban centers. And again, we see the same trend in the MassUp population as well. When we consider the resources that a community has, or how well-resourced a community is, we find that in addition to serving more rural communities, our data suggests that nurse practitioners play a larger role in providing primary care in lower income communities. Again, commercial on the left and MCO on the right. But we divide the populations who are attributed to an NP by income quintile. And we see a gradual trend where people living in lower income communities are more likely to have an NP as their primary care provider. So thus far, we've discussed the broader nurse practitioner workforce and the communities that NPs serve. And now we'll discuss the practice experience from the perspective of NPs. As Laura mentioned, we're fortunate to have data from our partners at DPH to share directly from NPs from the licensure renewal survey. DPH licensure renewal survey data indicates that a majority of NPs, 97%, report having a national provider identification number. This is an important prerequisite for billing because you bill using your NPI. And so without an NPI, you could not be expected to bill as an independent practitioner. Additionally, 37% of primary care nurse practitioners report being listed as a PCP in an insurer directory in 2018, and this is up from 31% in 2016. So that is a good trend in terms of growing the number of nurse practitioners that are actually listed in an insurer directory currently. But this survey also asked about practice barriers in the two most recent years, in 2016 and 2018. And 17% of nurse practitioners report practice barriers due to employer restrictions. And we see some variation by the setting of practice. For example, in a hospital outpatient setting, this number increases to 23%. Additionally, 1 in 5 respondents reported practice barriers in the form of reimbursement restrictions from any payer. And again, we see some variation where it grows to 25% in a hospital outpatient setting as well. So these reported barriers have implications as well, and we're able to observe some of these in the claims data. So what we're trying to capture on this slide is a phenomenon of incident to billing, whereby a nurse practitioner provides a service, but a physician that is supervising them, presumably, is the one who is billing for that service using their NPI. And so in this graph, we have commercial on the left and MCO on the right, And we're observing the proportion of claims for evaluation management visits that were billed directly by an NP in the blue section, and then the orange section is illuminating the visits that were an NP delivered based on a procedure modifier, but were billed by a physician. And we see that across both the commercial and MCO population, we get to at least 27 or 28%. It's possible that this is an underestimation in some ways, given what we know about incentives to bill under a physician's NPI. But it's important to note that Medicare rules suggest that or pay 85% when a physician service is billed under the NP's own NPI, but 100% of the physician rate when the same service is provided by an NP billed incident to a supervising physician. There are other payer guidelines that are available, but this is an area that we're trying to understand as it relates to efficiency and cost, and also being able to tie service delivery to a particular provider. Because when a provider is not able to bill under their own NPI, it's hard to determine who actually provided that service. And so Ron will get to your question about cost here on this slide, where we're able to try to summarize the commercial prices for a medium level established evaluation management visit when it's provided by a physician, when it's provided by a nurse practitioner but billed by a physician, and when it's provided by a nurse practitioner and billed directly by that nurse practitioner. And so those three bars, in the yellow is that physician visit, the orange is the NP visit that was billed by a physician, and the blue bar is the NP visit that is billed directly. Across all of the claims that we can see in our commercial APCD on the left side, the overall suggests that the nurse practitioner visit that is billed directly is 62% of the physician rate, and we do see variation by provider organization that we're still seeking to understand through conversations with payers and providers alike. But we see that in some organizations it is lower than that 62%, and in other organizations it is much higher as well.
So I just want to highlight a point here, because it seems in cases where the nurse practitioner is delivering the services, but it's being billed under the physician rate on the overall chart there, in that circumstance, the reimbursement is pretty much very close to what if the physician had provided the services themselves. And we know that being able to hire and the salaries of nurse practitioners are lower than the primary care physician. So in those circumstances, the provider organization is using perhaps a lower cost practitioner to actually deliver the services, but the reimbursement is essentially the same. So this becomes in some ways a revenue generation mode for that provider organization in terms of being able to bill at that higher rate.
Are the differences, so for a particular provider, if a nurse practitioner sees the patient and it's billed at the physician rate, has something different actually happened, or than if the nurse practitioner billed, or is this a coding strategy?
I would say it's hard to know exactly from the provider organizations what the strategy is, because none have told us explicitly, but there are particular procedure modifiers that are indicated for the use of indicating when an NP provided a service, but it is explicitly being supervised by a physician in some capacity. And so what that means, it doesn't necessarily mean that the physician is in the room with the nurse practitioner with that patient as well. It means that maybe they signed off on documentation or there was some consultation. It's kind of a gray area in terms of what is the criteria to use that particular procedure modifier to indicate that it was appropriate for the physician to bill for the service, but indicate that a nurse practitioner delivered it. I think that's an area that we're still trying to learn a lot more.
I think tied to that is also the role of team-based care, and if you have a team with a primary care physician and a couple nurse practitioners and a couple PAs, what's this end up looking like as well?
In Medicare, the second of these bars is supposed to be 85% of the person.
So we're a little bit unclear why it seems so much lower in our claims, and one of the things we're trying to tease out more is we're combining lots of different sites of practice in these commercial prices that we're presenting here. So that's one thing that we're going to try to understand better, and we hope to also talk to some of the providers as well to understand that.
Wait, I'm sorry, let me just make sure that the orange is supposed to be lower than the yellow, is that Medicare. And then the blue would be supposed to be the same as the orange. Medicare.
David, can you say that again?
So in Medicare, if the visit is to a nurse practitioner, it's supposed to be at 85% of the physician rate. So both the orange and the blue were a visit to a nurse practitioner. So they're supposed to be at 85% of the yellow rate, which is the visit to the doctor. In Medicare.
No, I think in Medicare,
Here,
the
it's
blue should
100.
be 85%.
Yeah.
and
Yeah.
Orange.
the
Yeah.
other one should be the same.
Oh, the yellow and orange should be the same?
Yes.
Yeah.
It's 100% when it's billed under physicians and PI.
See, when do you get to bill under the physicians and PI in Medicare?
In the same scenario that we're seeing here, this incidence billing, because there are certain criteria where incidence billing is appropriate, the physician send the same building usually, and the MedPAC has recently recommended that we stop this practice entirely.
And just move to blue and yellow.
And I think we've seen some publicly available payer documentation that is going that way as well. I mean, of note, these numbers that we're presenting are from our 2016 claims data. So we hope, if we were looking at it in 2017 and 2018, that we both see more nurse practitioners showing up, providing any service, and we would be interested to see what the incident to looks like.
You briefly mentioned PAs. How do they play into that?
So, what we know about PAs is that they do appear in our commercial data, and through our attribution model, we find that around 9,000 commercial members in our APCD are linked to a PA. I think there is less that we know about PAs that we would like to learn more about, and it's definitely an area for a future study. But I think what's unique and why we're talking to nurse practitioners now is the explicit scope of practice restrictions that are still in place in our state.
If you took this diagram and did a slightly different analysis where you took 100 patients who saw an NP by provider, what proportion were billed as blue and what proportion were billed as orange, would the providers differ from each other, or are some doing more of the double of more orange than blue, or not? They all look the same.
So we haven't done that exact analysis yet, but it is definitely something that we can do. And I think the next slide will indicate a little bit more. And I do expect that we would see variation, if only by the nature that the percent of the primary care workforce does vary by organization. And so if you have the workforce to support more use of nurse practitioners in your workflow, I expect that you would use them. And so we do see that there are certain provider organizations that do appear to have many more nurse practitioners on staff in primary care than others, and we can definitely look into more of what you suggested.
If not, my question, no matter how many nurse practitioners you have, for a patient that sees a nurse practitioner, what proportion are billed as?
Are there provider orgs that are more likely to do incident to billing as opposed to? And I don't think we've put the data that way yet, but one of the things that we want to get to in our future research is, I'm jumping the gun because this is slide 50, is to understand why there is variation in the use, even the employment of nurse practitioners by these different provider orgs. So we can talk to
Okay. So based on what we've shown, we know that only a fraction of nurse practitioners working in primary care were reported by payers as acting as primary care providers for patients in 2016. As Laura mentioned, we hope that this is a trend that is growing over time, as we know that the nurse practitioner workforce has grown, and we would see more payers reporting more nurse practitioners acting as PCPs. We know that patients living in low income and more rural areas are more likely to be served by nurse practitioners, and we believe that the literature and evidence that we've seen indicates that restrictive scope of practice laws and other possible payer and provider restrictions could be limiting our ability to fully utilize the nurse practitioner workforce and expand access to primary care. Based on what we've read and what we've learned, incident to billing does appear to increase spending and inhibits our ability to accurately assess performance and quality across different types of providers and different types of provider organizations. And so,
one thing's for sure, the NP has increased access to medical care. Do you find that the physicians panel has decreased in size since they manage effectively the NP, or has the physician panel remained the same and then they just increased the number of patients by adding the NP?
So that's an interesting question. I don't think we've tried to like estimate average panel sizes for, you know, primary care physicians and provider organization A versus B, but that is something we could do to see if it's changing over time. Yeah, in theory, their panel should shrink.
Question. In the other states that you looked at, where the NPs have full practice authority, do you see a lower prevalence of incidence billing?
So I can speak anecdotally from looking at Rhode Island's APCD, and we definitely see lower use of the procedure modifier that would indicate incident to billing. Incident to billing is one of those things that we're lucky that we're even able to say anything about it now, because it's something that otherwise is done, you know, behind a closed door, and you can't really know who's actually providing a service unless you're in the room. But at least from Rhode Island, which is one of those states that has full practice authority, we definitely see much less use of that procedure modifier. So in conclusion, we're excited to do more research on this topic. We think it's really important and exciting for the future of the primary care workforce in our state and beyond. We're looking to evaluate more claims-based quality care measures and look more deeply into annual health spending for patients attributed to a nurse practitioner or a physician PCP, and to better understand how different provider organizations may be approaching employing nurse practitioners and how they're incorporating them into their workflow as well.
We've recommended to the legislature in the past expanding the scope of practice.
Yes.
Is there anything more we can do? I mean, obviously we haven't gone through all the quality things and so on, but assuming we thought we should do more, is there anything more we could do?
I think this presentation continues to add objective data and research that supports this case. I do know that there was a legislative hearing on a bill that would remove the restricted scope of practice law, actually I think just last week or within the last 2 weeks. And there has been I think a growing momentum on Beacon Hill to address this issue. It is something that Governor Baker had filed in previous legislation, and so as the legislature and the administration are thinking about healthcare cost containment legislation, we want this to be in the forefront of their minds again as a great recommendation for increasing access, increasing value in the healthcare system. So I believe we're doing our part and our job in terms of giving them the data and research to be able to support that case.
These data suggest to me that you have to wed that with a deep look at incident to billing and the statutory and regulatory frameworks.
Great stuff. It's a really it's insightful. The APCD does include ICD-10 data as well, right? So I think it would be really useful to overlay diagnoses into this, at least selected diagnoses. There was a little bit of a clue in the risk scores that MPs see versus what the physicians see, and I think you can choose a few rather than all 90,000 ICD-10 codes to take a look at that as well, because at least intuitively, nurse practitioners do a lot more acute care and physicians do a lot more chronic care. So it'd be useful to, I think it'd be very useful to have maybe at least a couple of slices of ICD-10 data overlay.
I suppose we could also ask the secretary if there's anything more that information that if we provided would be helpful. You may not have an answer now.
It's a great foundation.
Okay, why don't we, thank you so much. In the interest of prolonging our high blood pressure, we will not go through all of administrative complexity now. But if we start off on it, maybe we can get a little bit there, and you can leave us hanging with hypertension as long as Dr. Tyler gives us the appropriate medication for our next meeting. If you can find a good spot to do a little bit, let us ask some questions, and then we'll pick it up next time.
Sure, I think we have far too many slides, too much information at the get-go, so, still far too much information. We'll try and give you some of the greatest hits.
Instead of rushing through it all, just choose a part to do.
Here, let's just do the first couple of slides on the quantification and then we can end here.
Sure. Instead of, I don't want to rush through it all. I'd rather take it in parts, giving each part the time that it ought to get.
Wonderful, that's great. So, to provide some background and context for our discussion, which may continue after today, we do begin with some information quantifying payer and provider spending on administrative activities. So, our primary focus is on billing and insurance-related activities. Now, researchers generally categorize all payer administrative spending as billing and insurance-related, basically because anything an insurance plan does is insurance-related. But for providers, billing and insurance-related activities are those required to interact with health plans. So everything from provider credentialing with the payer to billing and claims, to prior authorization, dealing with formularies, reporting on quality, etc. All of that is under this rubric. Nationally, researchers estimate that billing and insurance-related administration accounts for $496 billion annually. It's approximately 13 to 14% of national healthcare spending. A lot of that is on the provider side. Hospitals, physicians, and others spending over $280 billion a year on these activities. Private payers about $158 billion, and public about $56 billion. If we include all administrative expenses, including those not related to billing and insurance, we get to about 30% of healthcare spending nationally is on administration. Now, if we look at all administrative spending just on the payer side, private and public, we see that these expenses are substantially higher in the United States than in other countries. We have the highest share of our spending in this area among all OECD countries. And I'll just note that includes countries with single payer and countries with multi-payer systems, so that's not the defining characteristic. Speaking of payers, in Massachusetts, the sort of net cost of private health insurance as calculated by CHIA in 2017 was $2.5 billion. That includes spending on everything from taxes and fees, broker fees, general administration, as well as profit and contribution to reserves. So this is everything that is not claims. We have some more detailed information on the administrative cost breakdown for commercial fully insured plans, as you can see, which spent $1.3 billion on non-claim expenses. So if we focus just on the cost containment and claims adjustment buckets of that, we see that 8.9% was spent on cost containment and 13.7% on claims adjustment, which is just about $300 million a year. So these are somewhat broad categories, but we expect that they do include activities like prior authorization and billing and claims processing, as well as other activities. Note that a portion of the claims spending, so not the non-claims, but claims, does cover administrative costs for providers, right? You give money to providers and they spend some of it on their administration dealing with payers. So,
what share, do you know what the $300 million as a share of total revenue?
Share of total revenue is going to be much smaller. Let's see. I don't have it in front of me. It ends up, I can picture the spreadsheet. We can get that from you very easily. Yes, apologies. So, when we do look at what providers spend in this area, research literature has found that physician practices spend 10 to 14% of revenue on activities required to interact with commercial health insurance plans. Hospitals spend around 8%. In Massachusetts, based on commercial revenue for providers, this would be $600 to $840 million for physicians, $768 million for hospitals, adding up to $1.5 billion a year for providers interacting with commercial health insurance plans. So that's the background. There's a lot of slides.
So the rest of this presentation walks through some specific priority areas where both the payers and providers have identified some potential opportunity to move forward. We're not going to get through all of this today, so I think we're laying out a problem statement, and I think that tees up a good conversation that we'll have next at the cost trends hearings in our first panel, confronting complexity in the healthcare system, where we're going to have a panel of witnesses to dive into this. But as evidence from some of this research and data, this is a significant amount of healthcare dollars being used both by the health plans and providers on administrative expenses. And the question for the commission and for this community is there opportunities to be able to reduce some of that expenditures without compromising value or access or quality of care? And that is really the goal of this project moving forward. So that was a big problem statement, so we'll leave it there and hopefully entertain any questions or comments from commissioners.
David, do you recall who's on that panel?
We haven't formally put everyone on notice on who's on the panels, but it will be a kind of a good mix of both a health plan, a provider, potentially a patient voice here too, because often patients are also stuck in the middle of this complexity. So expect to have a good, diverse panel for that.
It's fantastic report. One of the key questions for this panel is what's in the way. It's not just where the costs, but some of this is sort of obvious, but what has stopped progress with the ability.
It will be a super important panel for us. It really is an incredibly important issue for us to dig into.
Don't forget the cost of data entry. So electronic medical records has been a subject that came up at last year's cost trend hearing. I think we had a witness or two on that subject, and that as an element of provider cost needs to be highlighted.
Any other comments? So far, my headache is rising, tension level's rising a little, and I'm sure you will do well, which I'm not hopeful at all. If we don't just yes, that's fine. I'll take 3. Okay, in the absence of anything else, are there any other comments that commissioners or others wish to make? If not, we will adjourn and have 2 minutes to change over the panels.
All right, we'll take 5 minutes to reset for the next meeting. Thank you.
Second meeting of the Care Delivery Transformation Committee. We have a rather full agenda today. We're going to talk about ACO certification, process update, advise on the RX program, data points, new data points around neonatal abstinence is being released, and then update on the chart evaluation and the MassUp program design. Before we begin the formal part of the agenda, using the Wendy Everett rule, as I move to the vice chair role, we want to free up time for and appoint a new committee chair for the Care Delivery and Transformation Committee. So if I would like to nominate Barbara Blakely to be the chair of the committee. Is there a second? Don, any discussion? All those in favor? Congratulations. I will now turn the meeting over to Barbara.
Easiest election I've ever won. This appointment is brand new, and so I'm going to depend heavily on Commissioner Cohen for support and advice through this process, as well as David. So with that election completed, let's turn to approval of the minutes. Discussion, comments, or corrections?
Move to accept.
I move to accept. Is there a second? Thank you. All in favor? Aye. Okay. Cool. Let's then turn our attention to healthcare transformation and innovation structure. Kelly, is that you?
See.
Okay.
I'll just quickly tee up this conversation. So first, the previous slide that was just skipped over. Again, reminder: cost trends hearings registered.
Sorry about that.
But I am very pleased to formally introduce Kelly Hall to this committee and to our stakeholders. Kelly is our new Senior Director for Healthcare Transformation and Innovation. We call it the HICT team. And Kelly joined us just a little over 2 months ago, and in classic HPC fashion was thrown completely into the deep end on all of the many different items that we work on. She has comes to us with a very distinguished career in healthcare policy and management, having worked at Partners Healthcare for many years, most recently working in some healthcare startup space, and joins our team as a senior director of the largest team now at the Health Policy Commission. We're just really excited to have Kelly with us, and she's going to be a great leader within the organization and all of the work here. And but she also had the benefit of coming onto a team that is a really strong team of a lot of really incredible managers and research associates and analysts, many of whom you're going to hear from today as we go through this presentation, as we'll have a number of different presenters, and you'll be able to see just the incredible depth and strength of the team that she's helping to manage and steer. So with that, Kelly, I'll turn it over to you to talk a little bit, very briefly, about some of the internal changes we've made with Kelly joining the team.
So, good morning, commissioners, and thank you for that nice introduction, David. So, as David mentioned, I arrived at the HPC about 2.5 months ago, and my first assignment was to take a look at the organizational structure, which had previously been divided into two distinct teams with distinct management structure, with distinct management functions, and think about how to bring them together into a single function. So what I want to do with you today, very briefly, is talk a little bit about the thinking behind that and what's resulted and what changes you can expect to see in the future. So I think it's important to note that the pre-existing structure was purpose-built to deal with the work that was in front of us. So it was largely built to support a number of large statutory mandates that you have, I'm sure, heard about in detail in some cases. So CHART, HC2, PCMH and ACO certification. Some of that work is going to continue. Some aspects of that work are designed to end. And so as we started to think about what the team should look like, we thought quite a bit about what the future work might entail and how to prepare for that in the same way in the past we prepared for the first kind of work. So what we came to believe is that in the future, some of these programs are going to continue, but we may well see more mid-sized projects with more variety in scope. And as a result, a rigid structure was not going to be flexible enough for us to accommodate and support that work. So, and we've seen that actually come up already in some of the new work that we've taken on, MassUp and the behavioral health portfolio in particular. So as we started to think about what was going to happen next, what we agreed was that we wanted to support the existing structures that support the work that's still ongoing, while building something new that eliminated what felt like arbitrary or unnecessary silos, gave us some nimbleness in terms of the way our work is designed and staffed, promoted cross-functional learning and professional development for the terrific team that David just described, and candidly enabled us to continue to deliver excellent work in a positive work environment. So what we've done is we've organized under a single team structure with a single name, as David said, Healthcare Transformation and Innovation, or HICD for short. I'm also really pleased to share that Catherine Harrison, who many of you know already for her excellent work as part of the Care Delivery Transformation team, will be working with me as a deputy and expanding her scope of responsibilities to the entire HICD portfolio. We will start to staff our work increasingly cross-functionally. So instead of relying on those silos, we'll be working across teams. So what will look different to you? As I said, you'll start hearing HICD a lot more than you'll hear CDT or SI or any of the other terms. You may be seeing familiar faces speaking to different kinds of work. And other than that, I hope this is largely seamless for you. And if it's not, please let me know and we'll try to improve that. So that's that. So from here, we're going to move on to an important body of work around ACO certification. I'm going to invite my colleague Mike to join me.
Good morning, Commissioners. So we wanted to provide a brief update on the status.
Grab the microphone.
Is that good? Okay. We wanted to provide a brief update on the status of this year's ACO certification process. So following a variety of engagements over the summer, this year's application period opened at the beginning of October, and applications are due this week. We anticipate that by the end of this week, 14 ACOs will have submitted applications for certification. Just a brief note on the numbers. You may recall that 18 ACOs were awarded certifications in 2017 and 2018. Of those, only 15 had their certifications up for recertification this year, and then 2 organizations that had submitted separately for certification in 2017 have combined this year and applied for certification under a single corporate umbrella. So the 14 total applicants this year represents applications from every ACO whose existing HBC certification was up for recertification this year. With the close of the application period, our review process is now beginning. In the coming days and weeks, we will be reviewing ACO applications for completion and working with the ACOs to ensure we have all the information that we need as part of the application. From there, our team will undertake a thorough review of ACO submissions for consistency with our 5 assessment criteria. As a reminder, our standards require that ACOs have a unique governing body that has the authority to execute the functions of the ACO, offers meaningful participation for ACO participants, and includes appropriate patient or consumer representation. And then in line with the clinical quality improvement and cost containment goals of the ACO model, we further require that ACOs regularly assess performance and implement strategies to improve in a variety of quality domains, implement population health management programs guided by routine stratification of patient populations, and coordinate care and services across the care continuum. So we anticipate issuing final certification decisions by the end of the calendar year, and then early early next year, we will be conducting analysis of the information collected during the certification cycle. These analyses will inform learning and dissemination activities in furtherance of the ACO certification program's transparency goals. That's pretty quick, but happy to take any questions on the certification program.
That's great, Michael, welcome. Could we make sure, if appropriate, could we make sure that the process includes a reflection with the ACOs on burden on them of the reservation process, so we can identify ways to streamline and simplify that for the next trustee?
Okay, so moving on to our next ACO related update, the AdviseRx Technical Assistance Program. So I think the last time that our team discussed AdviseRx was sometime in the spring, so I'll briefly provide some background information before describing the current state of the program. So we are undertaking this particular project at the direction of the Massachusetts legislature, which included funding in the FY19 budget for the Health Policy Commission to design and implement evidence-based pharmaceutical education program that provides information and education to clinicians on therapeutic and cost-effective utilization of prescription drugs. The budget also directed that at the conclusion of the program, the HPC submit a summary evaluation to the legislature describing the program's effectiveness. We made the decision to target this opportunity at HPC certified ACOs, and we performed outreach to the ACOs to inform the program design within the bounds of the legislative mandate. So we've spent the better portion of the past year designing this program. Earlier this year, we contracted with Alosa Health to deliver the program. Alosa Health has over 10 years of experience developing and implementing clinical education programs about evidence-based prescribing throughout the country, and we're very excited to be working on this project with them. As I mentioned, we also sought input from the certified ACOs to inform the structure and clinical focus of this program through a survey and one-on-one meetings. Using this feedback, the AdviseRx team determined that the clinical focus of the program would be on type 2 diabetes, and that the program would be structured as a staff training model to maximize value for participating ACOs. As such, Alosa will be training ACO staff members in the skills necessary to educate ACO colleagues on evidence-based prescribing practices. This approach will include a review of the current literature on prescribing for type 2 diabetes, clinical content webinars, and a 2-day in-person skills training session. After this clinical and skills-based educational programming, ACO staff will begin meeting with providers at their ACOs to discuss best practices, and will receive ongoing support from the Alosa expert staff through the spring. Alosa Health will also support each ACO in collecting and reporting the metrics, which will inform the summary evaluation to the legislature. So we opened up the AdviseRx opportunity to all of the HBC certified ACOs earlier this summer. Interested ACOs were asked to complete a short application that included a statement of purpose, outlining specific goals for participation in AdviseRx, and providing a description of how the opportunity aligns with the ACO's broader strategic goals for the upcoming year. The application also requested a description of relevant metrics the ACOs could collect and report on, as well as any data collection limitations. Finally, we requested information on the ACO's anticipated staffing for AdviseRx, and required that each ACO identify an internal champion to spearhead its participation in the program. Each ACO was allowed to identify a maximum of 2 clinical staff members to receive training in this program. Today, we are happy to announce that 4 HBC certified ACOs are participating in AdviseRx. Specifically, the HBC accepted Baycare Health Partners, Beth Israel Leahy Health Performance Network, which includes the Leahy Health and Beth Israel Deaconess Care Organization ACOs, Cambridge Health Alliance, and Signature Healthcare. Each of these ACOs is also participating in the MassUp ACO program. Those MassUp specific components are the Be Healthy Partnership for Baycare, Leahy MassUp ACO, Tufts Health together with Bidco, Tufts Health together with Cambridge Health Alliance, and the BMC Health Plan Signature Alliance. As you can see on the slide, some of these ACOs will be building on existing work in their organizations, while others are using this opportunity to develop a new body of work and advance their strategic priorities. These ACOs applied for the program at the beginning of the summer. They were notified of their acceptance at the end of September, and they will begin training with Melissa this month. Each ACO brings a unique perspective and set of resources to the program, and we look forward to working with all of them in the coming months. I can take any questions on AdviseRx.
Michael, is there a dissemination strategy for each of these? Because we're training two people, but how does it then filter down into the organization?
Right, so initially we considered whether to directly have a LoSA provide services for it to pursue the staff training model, and one of the factors was our sense that training staff to provide these services internally offered the possibility for greater sustainability within the organizations. So that will be part of the training.
Is there a reason why it's limited to two? I mean, some of these are pretty big organizations, and that might slow penetration.
Partly it was resource constraints, but as we went and worked with the ACOs, we discovered that given the time commitment FTEs that they're contributing to this, two is actually a limiting factor on their end as well.
Any other questions? Can you tell us a little more about LoSA?
We're missing our AdviseRx expert today because she's out sick. So I think why don't we, Catherine, do you want to jump in?
Sure. ALOSA is Boston-based, but they are a nationally known organization. I think their roots are here in the Harvard Medical School community with founding clinical expertise. They are a nationwide leader in providing academic detailing training. They have a variety of clinical modules available on their website for public use, but they work to tailor their work with individual provider organizations based on those organizations' goals, scope, particular clinical interests, and approach that they want to take to working with clinicians. So I think suffice to say they are certainly from our perspective well qualified, and we're really pleased that they've partnered with us to provide the training.
And I would note that the amount of money that we received in the budget, $150,000, is a modest amount. And so we do see this as an opportunity for learning and to understand, does this work? Do the organizations find value in this type of training? Do we see that it is actually helping physicians make more educated decisions around prescribing practices? I mean, this is just, I can't help but think of the previous meeting where we were talking about kind of physicians and the role of prescribers and understanding what is the best evidence for all of the different types of drugs. And so we do see a thematic link there. But we'll also learn a lot more from this small, modest engagement. And hopefully, if it works, then there may be an opportunity to seek further funds from the legislature to expand the program.
Is there any concern that the practices being recommended through this process bump up against the established practices of the programs? For example, practices usually have practice standards. Is there any possibility, or what might be the response to these recommendations bumping up against already established practice? And is there a mechanism within that practice to allow?
If I'm understanding your question correctly, I think you're asking me what happens if the advice that ALOSA is giving these folks bumps up against advice they're getting internally. I can't say that we address that question directly, but based on what we saw in the responses to the applications, what we did see is, first of all, in this particular area, these organizations seemed hungry for the advice, which would suggest to me that there isn't a lot of guidance out there right now for the particular classes of drugs that are a focus in the program. Also, I would say by and large, the staff participants are part of the ongoing dialogue within their organizations about pharmacy prescribing practices or general medical management practices. So I think, to the extent that there could be potential disconnects, I think there's a mechanism within those ACOs to resolve them.
Okay, thank you.
everyone, my name is Fran Hodgins, and I work on the 50 team as well, primarily on program evaluation, and today I'll be sharing some highlights from our most recent data points, as well as some highlights from our chart evaluation. But to begin, we released data points number 15 on Monday, which highlights both the prevalence of neonatal abstinence syndrome in Massachusetts and some findings from our neonatal abstinence focused interventions. So as you know, the neonatal abstinence syndrome is a condition that can affect infants with prenatal exposure as a result either of the mother's use of opioids and or prescribed medication-assisted treatment. Caring for infants can be complex and costly. The constellation of symptoms include fever, poor feeding, sleep disturbances, and can be as severe as seizures. And despite the risk for NAS, treatment with MAT during pregnancy is medically recommended by clinical experts and has been associated with improved maternal and fetal outcomes when compared to pregnancies involving untreated ODD. So historically, infants with NAS have required admission to the neonatal intensive care unit, or the NICU, for observation and administration of pharmacotherapy. A 2016 study, which is highlighted in the chart here, found that infants with NAS were admitted for an average inpatient stay of 17 days, and that average costs were around $67,000, even higher for infants that required pharmacologic treatment, which is significantly higher than $3,500 for an uncomplicated term infant. So across Massachusetts since 2010, we've seen an increase in the number of substance-exposed newborns and the number of infants diagnosed with neonatal abstinence syndrome. So as you can see here, in the light blue, we have the total number of substance-exposed newborns, and in the darker blue, the number of infants diagnosed with NAS. And you'll note that there was a change in ICD-10 codes between 2015 and 2016, which may explain some of the differences, but in general, we still think that there has been a rising trend across both of these categories. Today we won't have a chance to look at some of the interactive features of the online version of the data points, but one of the features that's online is an interactive map which shows some of the variation across the state. We see that different counties and regions are impacted differently, with Fall River and the Berkshires having the highest incidence of NAS per 1,000 live births. Thinking nationally, Massachusetts has higher rates of NAS compared to the most recent national data, with about approximately 16 per every 1,000 live births in hospitals compared to 8 at the national level. So in response, in 2017, the HBC launched the Mother and Infant Focused Neonatal Abstinence Syndrome Intervention Opportunity. The program was designed to improve care for substance-exposed newborns at risk for NAS, and for women in treatment for opioid use disorder during and after pregnancy. As part of the Healthcare Innovation Investments, the HCII program, the HBC awarded a total of nearly $3 million to 6 hospitals spanning across the Commonwealth. Awards ranged from $250,000 to $1 million for a performance period of 12 or 24 months. And the participating hospitals were Bay State, Boston Medical Center, UMass Memorial, Beverly, Lawrence General, and Lowell General. Since 2017, more than 400 infants have been treated as part of this program, and we collaborated with the Neonatal Quality Improvement Collaborative, NeoQuick, to provide technical assistance to the hospitals and assist with data collection. In the yellow, we have the core components of the care model, which all of the hospitals adapted to their context, but the 3 key components are highlighted here, the first being increasing non-pharmacologic interventions, which are sort of demonstrated in that blue wheel, and as you can see, some of the interventions, including rooming in and breastfeeding, are focused on both, providing a soothing environment for the infant and treating infant symptoms, as well as improving maternal-infant bonding. The promotion of non-pharmacologic interventions was a critical component of these programs, and hospitals found that non-pharm interventions are an effective treatment for NAS symptoms, either used in parallel or when appropriate as an alternative to pharmacologic treatment. Hospitals, the second piece here, hospitals also focus on optimizing NAS pharmacologic treatment, often through improving screening and scoring practices, either through the Finnegan or through the Eat, Sleep, Console methods. And lastly, hospitals focused on increasing access to services for mothers and infants post-discharge. Now we move to some of the findings that we've seen across our programs. So one of the goals of the programs was to reduce the length of stay for infants at risk for NAS. What we're seeing here is the 24 months of data collected after the program in comparison to the baseline period after the program launched in Q2 of 2017. And just to orient you here, the orange line is the actual data points each quarter, and the blue line is the median in the baseline and then in the intervention period. And impressively, we saw that hospitals observed a 53% reduction in the median length of stay among term infants from 17 days to 8 days. Hospitals also observed a drop in the percentage of infants that require pharmacotherapy to treat symptoms of NAS from 66% of infants in the baseline period to 42% during the intervention period. And we also observed a decline in the percentage of infants requiring care in the neonatal intensive care unit from 56% to 43%. So it makes sense to look at all three of these charts together as they're all sort of interrelated. Historically, infants have been administered pharmacotherapy in the NICU setting so that they can be observed, and often pharmacotherapy is administered over several days and requires a tapering period. As we see programs shifting to non-pharmacologic therapy to prevent or treat NAS, we see a reduction in the need for pharmacologic care, a reduction for the need to use the neonatal intensive care unit, and ultimately a reduction in the length of stay. I'll note that these are findings are promising and suggest that these models of care have the potential to both improve care for families impacted by opioid use disorder and the potential for cost savings. While we didn't collect cost data as part of this investment program, the significant delta between the cost for infants that are diagnosed with NAS and uncomplicated term infants suggests that these programs could result in meaningful cost reductions.
Fran, in all the cases, the improvements began before the intervention started. In fact, the intervention looks more like a helping aids than induce them. Do you think we signaled something by the program? Or how come?
So thank you for that question. Yeah. So it is true that many of the hospitals across the state and across the Commonwealth have been interested in addressing this issue, especially in response to the opioid epidemic. And we've seen other types of interventions, some of which have been promoted by our partner NeoQuick, and other things like baby-friendly hospitals that are promoting skin-to-skin contact and breastfeeding and other things. That being said, we still have seen greater reductions with the introduction of our programs and sustainment of those improvements over time. So that's definitely something that we have to take, like every intervention, it doesn't happen without the impact of other quality improvement and other efforts across the Commonwealth. But we still feel like there have been positive results associated specifically with the interventions that we funded through this program. I'll just end here to say that we're thinking about, as we think about outputs of these programs, wrapped up over the summer, and we're in the closeout phase with the 2-year awards currently. We released the NAS profiles in June of this year. This NAS DataPoints was released on Monday, and we're also conducting a comprehensive program evaluation that we're planning to release next summer.
So our next topic is one that I think will be familiar to many, if not all of you, which is chart. Interestingly, before Fran digs into the details, David and I were chatting yesterday, and we were saying, one of the advantages of being a relative newbie to the HBC is the opportunity to kind of look at some of the work with fresh eyes. And from my standpoint, it's really interesting to pause and reflect on just how far the market has come since the TAR program launched in 2016. And it's incredibly important to sort of look at the results, and in some ways get yourself into the mindset of what the world looked like back then. I mean, this was pre-Mass Health ACO and all of the changes the market brought there. As you well know, the program was intentionally directed towards some of the most challenged hospitals in the Commonwealth so that they could prepare for what's ahead, candidly at a time where it would have probably been a lot more desirable or certainly easier for them to focus on their day-to-day. So as I said, as a person coming to this with fresh eyes and trying to put myself back into what I would have been thinking in 2016, there's a lot of really impressive work here, and I'm delighted that we can give you the first dose of the chart final evaluation today, and then, you know, continue with that hopefully through the end of the year. So let me turn it over to Fran.
So to remind everybody, the chart phase 2 investment was implemented over 2 years across 27 community hospitals across the Commonwealth. And the goals of this program included integrating care across medical, behavioral, and social needs, shifting care from the hospital to the community, improving capacity to use data and analytics to better serve patients, and ultimately to prepare community hospitals to succeed in value-based care models. And I'll just note that what we're talking about today is the chart evaluation. There are a series of outputs that are all geared to highlight the many valuable lessons, slightly different audiences. We talked about the impact brief at the September board meeting. We're also working on a playbook, which is an implementation practical guide, as well as profiles of the individual hospitals. The evaluation that we're highlighting today is conducted across all of the cohort, and we're looking at a cohort level evaluation rather than specific hospital outcomes, and that we use quantitative and qualitative methods to inform this evaluation. So there are 3 main sections of the chart evaluation report. At previous CDT meetings, we have shared preliminary findings from part 1, design and implementation, and some of the key takeaways from the patient experience study as well. Part 2, which we'll be talking about today, shares findings from our mixed methods analysis of the program's impact, and we'll be looking at several of the outcomes highlighted in the yellow box. We're considering impact broadly in keeping with the transformative goals of CHART, and again, our findings are at a cohort level. And then the third part of the program is focused on sustainability, looking at both organizational change and programmatic sustainment. In terms of timeline, you can see we're currently conducting final analyses and drafting the report and targeting early 2020 for a release. And to kick off, we will start by examining how the CHART programs progressed in their use of data and analytics. So as we get started, you'll note that we evaluated 29 CHART programs. Funds were allocated to 27 hospitals, but some hospitals participated as part of a joint award, while other hospitals chose to implement more than one program at their hospital. So ultimately, 29 programs were included as part of this evaluation. Across the 29 teams, we saw that 28 of the teams made notable progress in the use of data and analytics. Building the hospital's analytic capacity was critical for guiding quality improvement during CHART phase 2, and also for preparing hospitals to enter value-based delivery models. When considering their progress, we looked at 3 key indicators: whether programs could generate real-time alerts when an eligible patient presented in the hospital, if they could create dashboards to track patients' progress and use data to inform operational considerations, and finally, whether they could conduct sub-analyses to stratify patients based on need. We had a lot of great examples and a lot of material across all of the awards, but we pulled out a couple of examples just to highlight what we're talking about. So for example, for real-time alerts, Holyoke noted that they had an ED tracker that would pop up patients who were CHART eligible, which allowed them to contact with them in a timely manner and engage them in services. Emerson noted the value of being able to review data regularly to inform their operational decision-making. And Health Alliance Hospital stratified their patients based on need and then matched the service intensity with the high, medium, low need of their patients.
Fran, who was the contact at each of these?
Are you wondering who the quotes are
Yeah.
from? That's a great question. So it varies based on what kind of what source we're drawing on from here. So we had a lot of written deliverables that were often completed by the program manager, but we also contracted with the BU School of Public Health that conducted staff interviews with a range of staff, so all the way up from people that are sort of working at the administrative level down to the frontline staff, community health workers, nurses. I don't have off the top of my head who these specific quotes are from, but we drew from all of those resources as well.
And the volume of responses?
Was high. Again, I don't have it. I don't have it right on.
Just ballpark. Are we talking thousands or hundreds or
No,
dozens?
hundreds. Yeah. But they conducted many interviews, and they also conducted patient interviews, although that's part of the patient experience. Okay. So the next area that we looked at is integrated whole person care. So all of the CHART programs serve patients with complex often intersecting medical, behavioral, and health-related social needs. And as we noted earlier, one of the goals of the CHART program was to integrate care across these needs and to think holistically about patient needs. 27 programs made notable progress in this domain, measured by increased assessment and documentation of patient needs, incorporating appropriate expertise into the team, either through training or hiring, and aligning care offerings with patient priorities, including visiting patients in the home or community, and assisting patients with resources to help them achieve their identified goals. We dug a little bit deeper to see what the focus area of each of the programs are. 22 of the CHART teams targeted health-related social needs, often through enhanced referrals or the use of patient assistance funds. 13 CHART teams targeted behavioral health needs, often through trainings for their staff or hiring staff with a BH focus. And then 6 teams targeted palliative care needs, often involving palliative care consults. As you can tell by the numbers, several teams chose to focus on more than one focus area as well. Another core element of the CHART model was community partnerships, and community partnerships enable CHART teams to further extend the impact of their program beyond the walls of the hospital and create a network of resources to support patients after discharge. We saw 28 hospitals make notable progress, marked by formalized channels of communication and the embedding or sharing of staff with partner organizations. So a couple of examples. Bay State conducted regular case conferencing with the Carson Center, which provides outpatient treatment for mental health and substance use disorders to provide additional support for patients with behavioral health needs. Addison Gilbert's CHART team nurses rounded at local skilled nursing facilities, which they found particularly important as patients were planning for discharge from the SNF. And lastly, Mercy embedded behavioral health network staff into their ED emergency department to conduct crisis evaluations as CHART patients came into the ED. And lastly, as part of the cohort-wide evaluation, we looked at the impact on acute care utilization for the eligible target population. So across all patients that were eligible for CHART, their intent to treat population rather than patients served. The data being presented today is based on self-reported data from the hospitals for their eligible patient population. And each program chose to focus on one primary aim, targeting acute care utilization, either 30-day readmissions or returns, 30-day ED visits, or ED length of stay. When looking across the cohort, impressively 24 CHART programs observed reductions in acute care utilization, with 16 reporting 15% or greater reductions for their target population. While 5 CHART programs did not observe reductions across their target population, many of these teams did conduct sub-analyses of specific populations and observed reductions within those groups. So before we move on, I'm just going to pause for a second. We initially looked across the whole cohort across all 29 programs, but then we felt that it was also important to break it down to look at what were some of the differences between the programs that were focused on ED setting versus inpatient setting. As you know, the choice to focus on the ED versus inpatient setting drove the type of patients that these programs were seeing, the type of staff that they had and where they were located, and the type of services that were offered. Across the ED cohort, we often heard that while patients were presenting with medical concerns, their ED utilization was often driven by behavioral health or health-related social needs. In contrast, in the inpatient setting, patients may have had a behavioral health or health-related social need, but these patients were often driven by higher medical acuity. And that kind of impacted how the programs were designed, and so we expected to see some differences in how they performed across these domains as well.
So just before we move on, do you see any opportunity either now or in the future to include the issues around social determinants of need and how to frame? I mean, you captured a bit of it, but how do we extend that? How do we include those issues and those measures?
Thank you. Yeah, that's a great point. And that was a major focus and I think a major area of learning that we heard from many of the programs. Several of the ED-focused programs already had their model was designed from the get-go to address behavioral health and health-related social needs. But for many of the programs, we learned from them over time that they recognized that it wasn't just medical acuity that was driving utilization, and so programs increasingly trained their staff, hired more community health workers, patient navigators, We're drawing on patient assistance funds, working with community partners to address health-related social needs, and that was a major focus for many of these programs, and definitely something that we talk a lot about. I think another way that the programs really addressed health-related social needs was by thinking beyond the bounds of the traditional walls of the hospital. So a lot of this care was delivered in the home or in the community, helping patients to connect with either government or local community service organizations that are offering support as they think about post-discharge. So following up beyond sort of what we may consider traditional hospital care. Okay, so as I was saying, we looked at each of those 4 domains that we just discussed at the cohort level, but looking just at the ED and inpatient results. Roughly, it's not exactly half, but roughly half of the programs were ED focused and roughly half were inpatient focused. So thinking about use of data and analytics, we observed that there was a greater focus on the use of technology, data, and analytics in the ED focused cohort. Practically, ED programs had a shorter amount of time to connect with patients, and so many ED programs developed capacities for real-time patient identification and tracking. In the inpatient focused programs, we saw greater uptake of care management tools and use of risk stratification to target services. Thinking about integrated whole person care, across the ED cohort, we saw that all of the programs integrated whole person care, particularly for behavioral health and health-related social needs. We saw a lot of assessment and documentation of behavioral health and health-related social needs and incorporating that into the records, enhanced referrals, and trainings around behavioral health. The majority of inpatient programs also made progress here. However, some of these programs had patients with higher medical acuity and therefore had less bandwidth to address a broader spectrum of patient needs.
I'm sorry, just before we move on, for the purposes of this research, what would integrated whole person care look like?
Yeah, so it is a little bit of a broad term, and part of the reason that we kept it that way is that it depended on who the patient population was, and so we tried to think about that. Say for example, the target population was patients with behavioral health diagnoses, then we were looking to see, okay, are they improving documentation around behavioral health diagnoses? Have they incorporated staff that have behavioral health expertise? Are they connecting them with services, in the community, for example? Whereas other programs, maybe they had a greater focus on palliative care, and so then we kind of used similar types of domains around, did they document, did they connect them with a palliative care consult? Were they coordinating care with SNF or other, services outside of the hospital? So the term is a little bit broad, but those are the 3 categories that we use to define integrated, is around documentation, around did they have the appropriate staff and expertise, and then were they delivering services basically to meet the needs identified by the patients, marked by, visiting in the home or community, enhanced referrals to other services, accompanying patients to their appointments, helping them fill out SNAP forms, that kind of thing as well. So we also looked at community partnerships and acute care utilization. Both ED and inpatient focused cohorts worked to develop community partnerships, but as you can imagine, the type of partnerships differed between the 2 cohorts. For example, the ED focused programs more frequently embedded behavioral health staff or built relationships with BH focused community partners, while many inpatient programs focus on partnerships with skilled nursing facilities and elder service organizations. Shifting to acute care utilization, we saw across all of the ED programs that they were able to reduce utilization measured by ED revisits or ED length of stay, and impressively over 2/3 achieved a 15% or greater reduction. Performance was more mixed for the inpatient programs, but the majority did see a reduction in readmissions, and again, many of these teams observed reductions in subpopulations. So thinking back about our kind of comprehensive evaluation report, last time we talked about implementation and inpatient experience, and today we touched on several of the impact domains. And next time that we meet, we can talk in further detail about acute care utilization as well as sustainability. The next discussion of acute care utilization will be informed by a cohort analysis conducted by the BU School of Public Health, which is still incorporating final data, but we expect to receive that shortly.
Great results. obviously great work being done in these hospitals. I'm curious, actually three things. One is the sustainability, which I realize is the sort of next phase of the evaluation, so I'll be patient. The other is there's a couple here where they did not meet. I always think you learn a lot from the places that didn't produce the results you were looking for. So are we capturing that in a way that we can learn from? And then my last point is what's our dissemination strategy here? Because I think the work done in these hospitals could certainly be replicated in other settings.
I agree. I will put a pin in many of the sustainability questions, but just to preview, we did see that the majority of hospitals sustained part or all of their programs, and several of the CHART programs are also, or CHART hospitals are also participating in the SHIFT program, which is currently happening right now. To your second point about the programs that did not meet, I think there are sort of two things that are happening there. In some cases, we did see that hospitals really encountered barriers to implementing some aspect. For example, I'll use data and analytics because that one is one that we saw. There were a lot of tangible barriers around electronic medical records, around getting systems set up. In other cases, it really wasn't so much that they encountered barriers as it wasn't a focus of the program. So for example, I know that there's one that doesn't have as strong of a showing around community partnerships, and really it's just that their model was not designed, that was not a main consideration in their model, and they were more focused on within the hospital, the resources that they have there. We definitely touch on what some of the major barriers are and what some of the learnings were over the course of the CHART period as part of the full evaluation report.
I think it's also worth noting, though, that as we look at the hospitals that fell into those orange bars, there wasn't any single hospital that appeared consistently across all domains. There was nobody that was sort of across the board failure. It was much more heterogeneous than that, and spoke specifically to some of the issues that Fran described.
And then I think lastly, in terms of our learning and dissemination strategy, that's something we're talking about a lot. And as I mentioned earlier, we have several outputs that are all kind of geared to different readers and audiences and thinking about how we want to use them. I don't know if you want to add to this, but we certainly are excited to share the results of this and looking forward to sharing with all the hospitals, sharing with putting it online and sharing with our other partnering organizations at the agency.
Yeah, and I think specifically the CHART playbook will speak to the opportunity to provide real-world, tangible lessons to other provider organizations that might want to build off these learnings for their own programs. But that's just one of at least 4 different flavors of content we're developing, and we can share that in more detail next time.
The results that we have right now are at the program level. Are we going to be able to denominate in the individual number of patients? In other words, the BU report, is it going to show numbers of patients affected with each program? And as we move toward a cost-benefit analysis, what we have that available to us?
So the BU analysis is also at a cohort level, so we'll be looking at a cohort level. In terms of seeing, and the evaluation report will also stay at a cohort level. We also are working on developing profiles of each of the hospitals, which have more specific information and data highlights from each program, which may be able to speak more specifically about at the site by site what kind of practices were implemented and what some of the results were.
So is, as part of sustainability, doing a cost-benefit analysis?
So we've talked a lot about cost-benefit analysis and sort of what is the return on this. We didn't collect cost data as part of our analysis, and we think that hospitals are best positioned to talk about the ROI, given that they have their cost and revenue data, as well as have the ability to make the judgment calls about some of the items that it's hard to put a dollar amount on, such as patient and provider experience. When we talk about sustainability, though, we did ask all of them to engage in a strategic planning process in which they spoke to what the value of this program was for them. Some of them did speak specifically about ROI, some of them it was more general, and then we have an indication of how valuable it was to them based on sort of the level of sustainment as well.
Just following on Marty's question, do we have a relationship with Mass Hospital Association so that their statewide or regional meetings can be populated with not just
it's a great question, and in fact, at our last learning and dissemination strategy meeting, we talked specifically about the opportunity to sort of build our network of dissemination partners, and MHA was absolutely one of them.
I'm so impressed with the written products here, and the reports are great, the graphics are great, but there's also complementary value of showing off in here and having actually the hospital themselves talk to other hospitals.
Yeah, absolutely, and I think one of our jobs is to inventory what those opportunities are, both to push content, as we just described, but also, to your point, to be present, to be a resource, to just be there, answering questions, sharing what we've learned. Okay, if there are no further questions, we'll move on to our last topic, which is MassUp.
Good afternoon, everyone. So as Kelly said, our final agenda item for the day is to talk to you about this program that we introduced you to back in June, called Moving Massachusetts Upstream, or MassUp for short. Some aspects of this program are already underway, but some are still taking shape, and in particular, the investment program aspect of MassUp remains in design. So the purpose of our talk with you today is to sort of update you on where we are, share our thinking right now, and then hopefully engage you in a discussion so that you can provide your reactions and input to us as we continue to design that. So just to recap, in June we introduced this program to you. And as you might recall, this is really an initiative through which the HPC is partnering with several state agencies, including the Department of Public Health, the Office of the Attorney General, the Executive Office of Elder Affairs, Mass Health, and of course all with the support of Secretary Sutter's office. And all of these organizations, what we share in common is that we do work with healthcare organizations, and we both have responsibilities for and opportunities to influence them in their operations. So this MassUp initiative was really born out of the desire across our state agencies to be more aligned and more collectively focused on supporting the engagement of the healthcare system in partnering with communities to really understand and address the local and societal conditions that so powerfully influence health. And these are the upstream factors, if you will, that shape health outcomes and that underlie health inequity. So our state agencies began meeting last year to take stock of the various expertise, tools, and touch points we have with the different parts of the healthcare and social service sectors, and to think about the opportunities we have to contribute to this work. And we did come out with an action plan that includes several prongs. One is an investment program that I mentioned that would be funded by the HPC, under which we anticipated making awards to a small number of community collaboratives, or really partnerships between healthcare organizations and community-based organizations to align their current activities and address the social determinants of health, and really expand that work in an upstream direction. With the expertise of DPH, really in supporting community-based public health activity, we envisioned that DPH would provide technical assistance to those funded partnerships. And meanwhile, at a state agency level, we also committed to continue to meet across our participating organizations and undertake our own internal alignment work, both to catalog and to try to rationalize the various programs and policies that our own agencies are accountable for. And to work with participants in the investment program also to troubleshoot policy barriers that they might uncover in the process of trying to do their on-the-ground community work. And finally, in order to make sure that the successes and challenges of all this work could be rigorously documented for future learning, DPH has also committed to funding an evaluation that would help illuminate the key conditions or ingredients that make for productive change at the community level and in the broader policy scheme. So that's kind of the background, which again, hopefully is familiar to you from our last meeting. And that really brings us to today. So what we've been up to since we last spoke with you about this is to do some more work to really try to continue to move from this kind of conceptual stage to really having a program design, particularly in terms of the investment program. what we really wanted to be able to start to visualize and be able to articulate what kinds of partnerships we wanted to support, what kinds of activities we wanted to be able to fund, and that's what we'd like to update you on today. Okay, so unlike some other HPC investment programs where we set out to really try to spread a particular care model or tackle a particular measure like avoidable ED utilization, or focus on one specific actor in the healthcare system like a community hospital. With MassUp, from the outset, I think we are acknowledging and realizing that this work is a little bit different. This is really looking at building effective linkages and collective power within a community to change structural barriers to health. And there's probably no one model or one way to articulate exactly what that can or should look like. So this is just not going to look the same from one community to the next or one partnership to the next. So the more we tried to hone in on exactly what are we trying to do here and what are the design elements that we should really put in place, the more it became clear that there would be great value in understanding a broad range of examples of work in this space that's already happening across the country. So we did engage in research of various sorts through both secondary sources and through primary interviews with a variety of organizational and program leaders. We were particularly interested in seeing examples of health system community partnerships doing upstream work and to query them about things like, how did you get started? How do you get organized? And has your organizational approach changed over time? What kind of local community engagement did you do? What did that look like? How did you plan your work? What kinds of resources did different partners bring to the table? And what was missing? What did you need that you didn't have at the outset? And we spoke with representatives from several specific programs. We also gathered a lot of information from organizations that are already funders in this space, that make grants to enable this work, or that have sort of organized networks, such as Moving Healthcare Upstream, the Democracy Collaborative, and others. And to round out that focus, which was largely on organizations and programs outside of Massachusetts, we also spoke with some local organizations that we know are engaged in the work of cultivating partnerships between the community or the social service sector and the healthcare sector, and some of those are shown here as well. This is just really a snapshot. There are a lot more resources that we consulted and people we've tried to talk to all along the way. But really in this research, our goal was to expose ourselves to a wide variety of models that could inform our design. Okay, now briefly, I want to try to share with you some of the key themes that we have taken away from all of this research. So the first is, in the context of a partnership, this may seem very intuitive, but I think it's important to state, getting clear from the start on the roles of the different organizations involved, what they're expecting to achieve, and how they would get there is critically important. Which is not to say that in each partnership there was a single formula for the roles of different organizations. To the contrary, we saw lots of variation here. But a common theme that was particularly, I think, underscored by some of the work that we looked at in other grant programs and other funding opportunities was an expectation that the partnerships seeking funding would come to the table with a pretty clear sense of both what they wanted to accomplish and how they would do it, and what roles various organizations would play in that. So we sort of anchored in on this principle that really understanding, knowing that this work is hard enough at the outset, having a clear definition of roles and expectations and strategies was critical. Second thing, our hypothesis that more downstream activities, if you will, like addressing health-related social needs, could really be fuel for or like building blocks of more upstream collaborative partnership work appear true. So one example that I will use to try to illustrate this, the Alliance for Health Equity, which is a collaboration of a number of hospitals in Cook County, Illinois, they got together to try to start to collaborate on conducting community health needs assessments. And from that work, which has been very successful, they've continued to meet and begun designing implementation plans to collectively address some of the issues that were revealed in their local communities through that process. important to note, on the flip side, I think we also observed that community organizations in these partnerships sometimes our focus already more upstream than their healthcare counterparts on issues like housing and food insecurity. And in those situations, leveraging a healthcare partner to come to the table to bring resources and energy and capacity that might not be otherwise available was also another way that these partnerships sort of took shape. A very important third point that was revealed to us through our research is that dedicated staff and resources are absolutely critical. I think we heard time and again that this work is not able to be done with portions of people's time, and that it really takes dedicated resources. Sometimes these sorts of dedicated staff were employees of a healthcare organization. In other cases, we saw a third-party organization like an expert consultant sort of being the glue that would help facilitate the partnership. But wherever we observed that there was a mature or well-established effective collaboration, we saw at least one or more individuals acting as dedicated staff, so we took that to heart. A couple more quick points. Data, critical to have and to understand the conditions and enable these partnerships to shape their goals. And I will say we're not just talking about numeric information. I think we heard there is no substitute for on-the-ground authentic engagement with community residents to understand how they experience their community and what their priorities are. And we saw this both in terms of some of the healthcare anchor institution examples that we reviewed, as well as in a program I'll mention called Healthy Neighborhood, Healthy Families, which is out in Columbus, Ohio, where particularly healthcare organizations made an effort to really understand and appreciate the assets and the challenges of the communities in their area, and it made all the difference. It engendered trust and support for the work, as well as helped them avoid taking steps that they might have thought would be beneficial, but that the local community might have seen in a different way. And finally, I think while we had hoped that we might find a silver bullet to the answer about how these partnerships should organize and govern themselves, it became clear to us that different partnerships have different dynamics and different needs around governance. In some cases, I think we saw partners fully establish a separate legal entity, and in one case in particular, that legal entity was constructed in a way that the community-based organization had majority ownership versus the healthcare organization with a minority stake. But that was far from universal. And other partnerships had various formal and informal approaches, including sometimes working through like a county level public health authority as a convener. So there's just a ton of variety here, and I think it has helped us understand that depending on what issue they choose to focus on, the specific goals, the resources that each organization in the partnership might bring to the table, the governance structures might just naturally look different and need to be different, and might even change over time as the partners' work evolves.
Just before you step off of that, given what you just said, can you concur or draw any inferences from shared principles of governance that might apply across the board? And when we don't have the specifics, can we look to principles and argue anything?
Yeah, I think that's really important and exactly what we're going to be trying to do. I think the one shared principle, and I think Kelly will start to get to this, that our thinking is coalescing around, is being very clear about an equitable representation of various interests. That can probably take a lot of different, take a lot of different forms. But as a principle, I think that's one that we're particularly acutely interested in.
I think given the fact that every organization is different, even though they provide similar care, when we can't talk about specific content or structure, to the extent that we can find and identify underlying shared principles of governance and propose those as opposed to structure, I think we can make it a stronger impact.
I think we would completely agree. And just to reiterate Catherine's point, the theme of creating equitability in the governance structure came up every single time. And recognizing that depending on the actors you bring together, some of them come to the table with greater financial resources, some of them come to the table with greater community relationships. Some people come to the table, in fact,
because they have been less empowered. And so it's really critical to make this work as true partnership to address that in formal ways through the governance structure informed by the kinds of principles you described. All right, I'm going to pick it up from here. So if Catherine just told you how she and I spent our summer not vacation, it's helpful to understand how this has informed the key parameters of our investment program. The purpose of the investment program is specifically to support partnerships that include provider organizations and community-based organizations working together to address upstream social, environmental, and economic challenges and enable sustainable improvements in community health and health equity. So that really hasn't changed at all. I think where we've gotten a little bit more nuanced, candidly, is in terms of our expected outcomes. I think one of the things that revealed itself through our conversations is that there's a real opportunity for internal alignment within participating provider organizations of the current work they're doing, even if 100% of it isn't going upstream. So, we heard a lot that the community benefits people don't really talk to the population health people, who don't necessarily talk to the CBO people, some of whom have never been out of the building talking to the community organizations down the street. So we think that there's a real opportunity to try to use this program to promote some alignment there, and alignment of resources towards a common goal. The second thing that I think we became more sensitized to is just being mindful that we need to initiate new work or investments that push activities further upstream to address a social need and a social determinant, I should say, in a community. And I think that was a valuable thing, because I know our colleagues from the DPH were right to remind us fairly regularly. There are community organizations who've been working upstream for quite some time. So let's not forget that they have some experience there. So let's acknowledge that, but also say that the purpose of this investment is to go farther, broader, deeper than we have before. Finally, again, and Catherine mentioned this, so I won't belabor it, but again, a really fundamental outcome here should be the establishment of cross-sector, community-engaged partnerships that can live beyond the term of this investment. This is a 3-year program. I would love to find a social determinant of health that could be resolved from front to back in 3 years. I'm not sure that one exists. But the relationships can exist, and the skill building can exist, and the desire to work together can persist well beyond the scope of this program, which, as I just mentioned, is going to be 3 years, likely including a grant planning period. That was something that came up fairly regularly. How long that planning period lasts and what it should entail, I think, will be a little bit based on what we see in terms of the responses, but we think that that's worthy activity to fund. And speaking of funding, the total is approximately $1.25 million from the Healthcare Payment Reform Trust Fund.